Hello and welcome to the Two View, the cutting-edge educational show for PAs and nurse practitioners in emergency medicine and urgent care. My name is Mike Sharma. I'm a practicing emergency medicine and urgent care PA in the Dallas, Texas area and an adjunct professor of PA studies.
Well, hey, Mike. I'm Martha Roberts, and I'm an emergency medicine NP and assistant professor in Northern California. What's going on?
What's going on is we're recording this during Thanksgiving week, and I'm so excited because, as we're recording this, my oldest daughter, Geeka, is, minutes away from college to spend a holiday with us. She's about 2 hours out from town here, so pretty big time of the year for our family. Even without the holidays, we just celebrated my son Goon's birthday party with several of his very loud kindergarten friends in a giant room without carpet. Poor acoustic choice on our part. My ears are still ringing from all the screaming kids. Although one of his friends, Eduardo, did tell me it was the best party I'd ever been to. And Eduardo is a pretty cool kid. So we feel pretty good about that. Martha, what do you have going on these days in California?
I feel like all I do is work. I say that every episode. Work, work, work. We're actually building our family medicine course through the Center for Medical Education. So we have several physicians and nurse practitioners, as well as Rick Bucata, working on this. And I'm editing about 300 slides right now. That's been my week. I worked a couple of shifts in the ED, and we onboarded a few new grads, which is always fun to do during the holidays because we're super busy and can really use the help.
Yeah.
And honestly, I don't really have any Thanksgiving plans. No one invited us anywhere. So, and I'm not cooking. So not much going on, but I'm excited to go to Vegas next week for our course. But by the time this episode is out, we know that it will have already happened.
Yeah, I know. It's crazy that by the time this drops, we will have been come and gone. Maybe that can be DJ Khaled's next banger. All I do is work.
Right.
Work. Yeah. Anyways, you wanted to challenge us for this podcast. You sent me a message after our last one. Maybe it was the Halloween spirit inspiring you. And you asked, could we do an episode all about blood?
Yeah, I was in a bloody mood, wasn't I? But I just, I had a few odd cases at work, including some persistent epistaxis, some lower GI bleeding, which is so scary, by the way. These people go so fast, as in they bleed out and die. So, we had a lot of really bloody wounds. One, this guy sliced his entire bicep open. That was really gross. I don't usually say that. So it's been a month.
Yeah, that is. I don't remember a lot of my patients, to be frank, over the years of doing this. The percentage of patients I remember is relatively extraordinarily low, but I still recall the poor old lady who came in with the complaint of cough, and then started coughing up blood. And she went into her room, and I saw the physician go in. I saw a nurse go in. I saw another nurse go in, and I was like, what is, and all of a sudden, people start coming out covered in blood. And I was like, what is going on in there? So yeah, these GI bleeds, you can't put a tourniquet on a GI bleed, which is very frustrating to me. I've tried. Kidding, I've not tried that. That would be really awkward. How would you even, anyways, well, look, I'm never one to back down from intellectual challenge. If it's blood you want, it's blood you shall have. And we're going to talk about two weird but serious headaches that have to do with blood. And the 2024 guideline updates on CPR, got to keep that blood going round and round, don't you know?
Yeah. And for the person on your list who has everything already, we're going to talk about a gift for the holidays that involves blood, a recent scientific statement from the American College of Emergency Physicians, ACEP, involving the management of elevated blood pressure in the acute care setting.
Oh, you know what? I screwed this up. This is actually a scientific statement from the American Heart Association. That's my bad. I a little inside baseball. I screwed the script up on that one. So,
don't worry about it, Mike. We'll just keep going. Listen, listeners, okay? I will actually, this is a good point that you bring up, Mike, because the American College of Emergency Physicians, or ACEP, has lots of recommendations on high blood pressure in the emergency department. So I would say, as a side note, check those out and the choosing wisely paths.
Yes.
And then, we'll talk about the recommendations from the AHA, who partner very closely with ACEP. So everybody just relax, okay? Nobody's bleeding out.
No, we're good. We're good. Well, listen, it is time for our first segment, the Wet Read, where Martha and I get 60 quick seconds or so to talk about something that caught our eye. When I think about headache emergencies, headaches I can't miss, I think of things like intracranial hemorrhage, temporal arteritis, also known as giant cell arteritis, meningitis, encephalitis. We're now going to talk about two other headaches you're going to want to add to your list of bad headaches.
I had a really bad headache the other day, Mike.
You personally
Yeah, I did. It was really bad. I had a really, really bad migraine, and it came on, I could tell slowly coming on. And as soon as I felt it coming on, I took the Tylenol, I took the Motrin. Sometimes I take Imitrex, but this time I didn't. I don't always like the way I feel when I take it, but then I loaded on the Compazine, and it took a good while for that to go away. I also doused myself with a little bit of lavender, and just because I honestly think it really helps my headaches because I just kind of breathe in and breathe out. But regardless of my problems, we've all heard about the ominous presentation of the thunderclap headache, which is not what I had, which is not a migraine. These are more severe headaches with something is not right kind of presentation. These patients describe the headache that reached maximum intensity in less than 1 minute, real quick. But what about a person who has multiple short-lasting thunderclap headaches? They come, they go, they come, they go. Really intense. They kind of go away, almost completely go away, then come back. Once the brain bleed is ruled out in these patients that we see in the emergency department, something to consider is reversible cerebral vasoconstriction syndrome, or RCVS. The authors of a review article in the American Journal of Emergency Medicine, which is a great journal, by the way, describes a thunderclap headache lasting for about 1 to 3 hours as the presenting symptom in about 94 to 100% of patients with RCVS. The pathophysiology behind this headache is some sort of abnormality in the muscular tone of the blood vessels themselves of the brain. And in most of the time, it's affecting women in their 40s. So, could I have been having these, Mike? I don't know. But now I've got a new thing to worry about because I wasn't really aware about these headaches until you kind of talked to me about them.
Well, in about 20 years, it'll be your problem, right? Because it's only women in their 40s that get this. Yeah, no sweat.
Oh, thank you so much. Yes. So you should consider RCVS in patients with recurring severe headache that could be triggered by things like exercise, coughing, caffeine intake, triptan use, or sexual intercourse. A thunderclap headache in patients in the peripartum period or with a history of either cervical artery dissection or posterior reversible encephalopathy syndrome, also known as PRES, P-R-E-S, is also concerning for RCVS. Once you rule out a brain bleed, like we talked about, CT, angiography, and MR with contrast are probably the most sensitive imaging modalities you have in the ED, but sensitivity is only about 80% with these studies. So the gold standard imaging study is actually cerebral catheter digital subtraction angiography. As you can tell from the name, this is an invasive study that will probably need to be done as an inpatient.
Can't say I've ever ordered cerebral catheter digital subtracting angiography in my career so far, but hey, there's still lots of years left, I suppose. Well, this is a tough nut to crack. There's not really an agreed upon treatment regimen for this process. I feel like calcium channel blockers are kind of like what you reach for with weird vascular stuff. Like you got some bad Raynaud's, let's do some, calcium channel blockers. You got Prinzmetal's angina, calcium channel blockers. So here we go, another weird vascular thing. The calcium channel blocker nimodipine results in resolution of this headache in about 70% of patients, but it doesn't protect patients against some of the emergent complications, which can include things like ischemic stroke, brain bleed, and that PRES syndrome that we mentioned earlier.
That review article from AJEM and references for everything we're going to talk about today can be found on our website, 2view.fireside.fm. That's the number 2, view.fireside.fm.
The weird headache that I'll be covering is something called cerebral venous thrombosis or cerebral venous sinus thrombosis. It's sometimes abbreviated as CVT or CVST, depending on which name you like, I suppose. As it sounds, the problem here is a thrombus, a clot in the major veins of the brain, the sinus of the brain, the sinuses of the brain. This is, again, most common in women in their 40s. What's up with women in their 40s having weird headaches? My shorthand clinical presentation for this headache is the patient that can't be having a stroke because of the absence of the typical cardiovascular risk factors, but still looks like they're having a stroke. Other presentations are headache with blurry vision and papilledema, seizures to include status epilepticus, altered mental status, even coma. I created a mnemonic to help me remember the risk factors here. Somebody with a stroke may be having a hard time walking, and so the mnemonic here is tipsy, spelled TIPC. Both times. And this breaks down into acute and chronic risk factors in a sense. It's a little bit, fuzzy logic, but just roll with me here. The acute risk factors are trauma to the head, infections to the head and neck, procedures to the head and neck, and oral contraceptives. That's the first TIPC. The more chronic risk factors are thrombophilias, inflammatory states, but that can be, transient inflammation, let's say after an infection or maybe after a vaccination. We were actually really concerned about these after the Johnson & Johnson COVID vaccines. We had a lot of people, or at least enough people, there was a safety signal in people having these crazy headaches here. So any kind of inflammatory state, pregnancy and postpartum, and cancer. That's the second TIPC. I mean, you could also just remember general risk factors for blood clots, but who doesn't like a good mnemonic, right? So this is a thrombus. So you might think, well, let me get a negative D dimer and that should be reassuring. It is somewhat reassuring, but it's not fully sensitive in terms of ruling out. There's no studies that say, yeah, for sure, negative D dimer equals negative CVT. The gold standard here is, again, another kind of unusual imaging study for the ED. It's an MRI and MR venogram. Because again, we're going to the venous vasculature, right, versus arterial. A CT venogram may be adequate too, and maybe more easy to obtain in the ED setting. Work with your radiology department to see how they can help you image this problem. That's usually my go-to, frankly, when I have a weird thing I want to image. I call radiology. I'm like, this is what I'm concerned about. Like, what is the best modality we have considering the equipment and the people on board today?
Yeah. Okay. Wow. I like your mnemonic. Also, don't hang your hat on those D dimers. They're so sensitive and they're not very specific. And I had a patient the other day who just barely crossed the red line to rule out for a PE and on the D dimer. Like if he had just been this tiny bit of a point less, we were kind of debating, should we scan him? Should we not scan him? And the guy had a PE. The D dimer wasn't even significantly elevated, but it was just only slightly positive. So are you really not going to do imaging based on the D dimer? I know there's lots of literature out there and every case is very unique. So just, consider the whole picture when it comes to D dimers. The road to hell is paved with them. So I digress. CVTs can cause swelling in the brain from a lack of venous drainage, or they can even cause bleeding from the thrombus. So either way, the treatment may involve anticoagulation, which sounds pretty scary to give a patient with a brain bleed. But the idea is that dissolving this clot will lessen the pressure in the system, and you'll have less bleeding. Other treatment options may involve IVIG, plasma exchange, or even thrombectomy. And these patients should be admitted to the hospital, of course, and probably neuro ICU. Talk to them. Talk to the neuro doctors. Those brain doctors, they're super smart. I love them. We have a review article from the New England Journal of Medicine, again, another great journal, on our website for further review. And that, again, is the 2View website here, which is 2view.fireside.fm.
Well, speaking of websites, I'm flipping through the Center for Medical Education's website. That is www.ccme. And I'm really excited because we have the live course dates and locations for the 2025 courses. These are great, fun courses to go to. They're always in cool locations when cool stuff is otherwise happening. How does it go again, Martha? It's kind of like half a day of lecture and then half a day of play, basically. Is that how it goes? Yeah.
To look at it that way is you'd have to figure out which area you're going to first.
Right.
And then, maybe it's only a quarter of the day because you care about the lectures in the morning, but not so much in the afternoon. And you really love Key West, so you need to go fishing. I mean, people do it every which way they want to do. We have great manuals that if you do miss a talk or a lecture, oftentimes it's very easy to get that material made up. So you do it pretty much the way you want to do it. But if you come to every lecture, yes, sometimes we put a day off in between, which is a really nice feature, which a lot of courses don't offer.
Yeah, so take a look at those locations and dates, and even kind of the rough schedule for each of the dates is up on the website. That is, again, www.ccme.org. Of course, while you're there, you can get the home courses, the self-study courses for all the things that we do, the original EM bootcamp, the advanced EM Bootcamp, where I got to pitch in and work on the EKG course this year. That was really a really awesome thing to do with Fred Abrahamian. We have the Mastering Pediatric Emergencies courses, the high risk emergency medicine course. Like, there's so much. You just pick what you want to learn about, and there's probably something that matches your taste on that website. That is www.ccme.org. If you are gearing up to get involved with one of the bootcamp courses, or really any of them, go to the bit.ly link. All right. So this is a bit.ly link that you want to go to. It'll identify you as a, friend of the podcast, that sort of a thing. It's bit.ly, bit.ly/EMBC Las Vegas. If you forget all that, don't worry about it. Come see us at our website, 2view.fireside.fm. We'll have that link there, along with everything we're talking about today.
All right, let's move on to segment 2. This is our dry scan, and we're going to penetrate a little deeper into 2 other topics. So way back on episode 2, wow, we covered the 2020 guideline updates for BLS and ACLS. Well, it's been a few years, so it's time to talk about the new guidelines, and these are from 2024. So the International Consensus on Cardiopulmonary Resuscitation and Emergency Cardiovascular Care Science, hot off the presses in November of 2024 in the journal Circulation, another great journal, love Circulation. But of course, just remember, when you read Circulation, it's about 30 to a million pages of reading. It's a lot of reading. Anything in Circulation is a lot of reading. This is, frankly, a very long document because this one is 108 pages, including all the references. So we can't cover everything, but at least we wanted to cover some of the new recommendations that are backed by at least a moderate certainty of evidence, which there are only a couple. We did not find any that were backed by high certainty of evidence. And so take all that with a grain of salt here. So, number 1, carbon dioxide targets. There was weak recommendation to target normal capnia, a partial pressure of carbon dioxide, 35 to 45 millimeters of mercury in adults with ROSC after cardiac arrest. Number 2 here, cooling. There was strong recommendation against the routine use of pre-hospital cooling with rapid infusion of large volumes of cold intravenous fluid immediately after ROSC. Number 3, oxygenation after ROSC. There was strong recommendation to use 100% inspired oxygen until arterial oxygen saturation or the partial pressure of arterial oxygen can be measured reliably. Blah, 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 blah. Wow, that was really something. Let me rephrase, Mike.
You want to go back to 3?
Let me start over for our audience members. I just a little side note before I tell you the third thing. It has been a very long day. So let me focus on oxygenation after ROSC, okay? We're saying there's strong recommendation to use 100% inspired oxygen, okay, until arterial oxygen saturation or the partial pressures of arterial oxygen can be measured reliably in adults with ROSC after cardiac arrest in a pre-hospital setting. So I think the idea here basically is it's hard to get accurate measure of blood oxygen values in the pre-hospital setting. And we know that there have been low to moderate certainty recommendations to avoid hyperoxemia in the past, based on some observational studies suggesting that there's actually harm when we over-oxygenate people. But that harm required pretty high oxygen levels that were rarely attained in those studies. Maybe the best practice to err on the side here of caution is not having your patient be hypoxemic if you receive someone from the hospital after ROSC. So considering not being concerned about that inspired oxygen in the early stages of someone's visit, getting a blood gas early, and titrating your oxygen from those readings. Also consider the patient's skin tone, right? What does this patient look like? Okay. I mean, we assess, we always know physical exam is so important. We covered on episode 36 about how people with dark skin are at risk for occult hypoxemia from a pulse oximetry. The pulse oximeter reading at a higher oxygen level when in fact their true level of oxygenation was significantly lower. This CPR guideline acknowledges that none of the studies suggesting the potential for occult hypoxemia were done on cardiac arrest patients, but it's still something to be concerned about. There's no reason to suggest that it wouldn't happen again in cardiac arrest patients.
Yeah, it's been months since we talked about that on the podcast, and I am still really struck by those studies on that sneaky, occult, false normal oxygen levels in our darker skinned patients. There could be this hidden hypoxemia, and that has such massive implications in patients presenting with so many different chief complaints. I need to make sure I'm still keeping that in mind. Well, the holidays are rapidly approaching, but what do you buy for the person who has everything? Might I suggest tourniquets? I hope I never have to use the bleeding control supplies that I have in each of my family's vehicles, but it's better to have and not need versus the other way around, to need and not have. Let us sell you on the importance of pre-hospital tourniquet application for someone with a severe wound to an extremity.
Yeah, I just want to say, when it comes to preventable death in combat, as I'm sure you know, and I probably shouldn't be the one commenting on it since I've never been to combat, but studies have suggested that 60% of those preventable deaths were a result of uncontrolled extremity hemorrhage. The next highest cause of preventable death was tension pneumothorax at 33%. In case you were wondering, I understand that civilian trauma on the roadways or on the sports field are different, but sadly enough, there have been plenty of stories of firearm trauma across the country and over the world for many years. Of course, we know this. It's not inconceivable to think that you could find yourself in a bad spot and need a way to control extremity hemorrhage.
Okay, but how much of a game changer is it, you might be asking? Well, a 2018 study in the Journal of the American College of Surgeons of a little over 1,000 patients with extremity hemorrhages to the vasculature suggested that in patients who had a tourniquet applied in the pre-hospital setting compared to patients who did not, the non-tourniquet group had an almost 6 times greater odds of death than the tourniquet group. Death. 6 times greater odds of death. How about a 2019 study in the Journal of Trauma and Acute Care Surgery that covered patients with major extremity trauma who either had a pre-hospital tourniquet applied versus people who didn't? And by the way, this study only covered patients who had an average of 23 minutes of transport time to the hospital. These were not long transport times, and yet, over that short transport time, patients in the tourniquet group required on average 7 fewer units of PRBCs when they got to the hospital. The rate of limb amputation was 9% in the non-tourniquet group compared to less than 1% in the tourniquet group. Again, over an average of 23 minutes of transport time to the hospital. That's a big difference for not a lot of tourniquet time required at all. And what's crazy to me is if you read the current edition, the 10th edition, of the Advanced Trauma Life Support Manual, the authors are very hesitant to recommend tourniquet use, even to us, people who are supposedly being trained in advanced methods of trauma life support. That's why you're reading the manual. Now, I would love to show off my little bleeding control kit. I just don't have it physically in front of the screen. What I think we'll do is we'll just kind of cut in an extra video later on into this place of me showing off my kit.
Might be, Mike, this is one of those things I really like to add to our Instagram reel. And if you're not following us on Instagram, I highly suggest that you do. In fact, I'm telling you, you're not allowed to splice that in later. I want people to go to our CCME Instagram site, and it's really easy to find. It's just CCME_courses. Follow us. We post information, short videos, we put feedback from our listeners on here occasionally, and it's really great. So go ahead, sign in, check us all out, and we'll put your video there.
Fair. Okay, so let's say you're convinced by those 2 studies, and I think have been pretty convincing. There's lots of places to buy these supplies. I'm partial to either the Combat Application Tourniquet, the CAT, or the Special Operations Forces Tactical Tourniquet. We call that the soft T from my military days. These can both be applied one-handed. in case you're having to help yourself and all you got is one hand to work with. Nowadays, the Committee on Combat Casualty Care, this is the committee that kind of says, yes, we'll approve the use of these tourniquets on the battlefield. That committee has really expanded the recommendations on tourniquets over the past couple of years. We'll put that list of recommendations in the show notes, so be sure you look for these particular tourniquets if you're going to buy these things or when you're going to buy these things. In terms of training, the American College of Surgery has a program called Stop the Bleed. That is a great way to spread training on bleeding control into the community. And by the way, around May, they have what's called Stop the Bleed Day, where they really try to have a big day where a lot of folks can take classes. And at least for a while, the national leader of Stop the Bleed Day was a PA. So that's pretty cool and a nice tie to our profession. Free classes are held not all the time, not just on Stop the Bleed Day. Probably near you, you can go to the Stop the Bleed website to find those classes. But don't let any difficulty in catching a class stop you. Like, you're pretty facile if you're listening to this podcast. You probably could figure this out with a YouTube video or two. The most important thing is having the supplies on hand. You know, in the words of Pedro Teixeira, MD, he's the lead author of the 2018 study I mentioned. He said, the ideal person to apply that tourniquet is the person who could do it the quickest immediately after the wound is identified. That scenario is the highest chance for the patient to survive. I couldn't agree with those words more. We know historically people can bleed out from extremity hemorrhage in minutes. So my suggestion for the holidays here, a sweet tourniquet, and I'd say even two, frankly. The life you save may be your own or someone you love.
Yeah, I always get people pocket knives to inflict bleeding in case of carjacking or robbing. So that's what I get people, because I work in San Francisco. Not that I've ever needed to use a knife, but and I'm not a violent person, but maybe I'll keep a tourniquet or two in there now after what you said.
Well, after you cut them, you have to save them. And so you get to do both. You can be like the hero and also the hero again.
Right. Okay. Let's get to our final segment, Mike. Segment number 3, it's our oral contrast segment where we get into all the nooks and crannies of a topic. And it's time to talk about the new guidance on elevated blood pressure in the acute care setting. This is the topic that I like to talk about the most with new graduates because there's always questions. And should I treat? Should I not treat? What do I do? What about this number? What about that number? And you know what? It's really straightforward, and we have some really great resources to share with you. This topic on a scientific statement from the American Heart Association published in the August edition this year entitled The Management of Elevated Blood Pressure in the Acute Care Setting. Go figure. Blood pressure is, of course, a vital sign. And as Diane Birnbaumer would say, vital signs are vital. And yes, we look at the blood pressure. Extremes of blood pressure can indicate a potential emergency condition. It can even cause end organ damage and a swell of other problems. So chronic hypertension has been estimated by many to be the second most preventable cause of death in the U.S. and the leading cause worldwide of death and disability-adjusted life years. So undiagnosed, untreated, it is the leading modifiable risk factor for cardiovascular disease in the United States and also significantly increases the risk of stroke and chronic kidney disease and so many other problems. Like, we got to get on this. We got to be better.
Yeah, if you haven't figured it out, it's a pretty big deal. We could spend an entire podcast covering the guidance on what to do with somebody in the outpatient setting, like in a clinic setting with confirmed hypertension. However, there's a lot less data available that kind of is the evidence base for managing elevated blood pressure in the acute care setting where we practice, and practices very wildly through American healthcare. You ever been asked to give a blood pressure medication like clonidine to a patient you're admitting because the blood pressure was above whatever guidelines the floor or unit had for acceptable blood pressure, or you had a discharge delayed because someone really wanted to make sure you knew that the patient's blood pressure at discharge was not below 140/90 and confirm you really wanted to discharge them like that? Yeah. practices vary wildly. Let's talk about what this scientific statement recommends and what are some defensible ways, not defensive, but defensible ways that we can practice to not miss true emergencies and also set the patient up for good follow-on care after our acute care visit.
Yeah. Also, I just want to say I'm looking at the ACEP guidelines here, and I'll talk about some of those critical questions that they ask and then answer for you on their site, which is just acep.org, acep.org. But first, let's go over some definitions. The authors use the term acute care to refer to care received in the emergency department. I feel like this could be applied to care received in an urgent care clinic or, one-off visit when someone is presenting with an acute condition too. So elevated blood pressure in this document is being defined as a systolic blood pressure of 130 or greater or a diastolic blood pressure of 80 or greater. So common current terminology for a patient with systolic blood pressure greater than 180 or a diastolic greater than 110 is considered hypertensive crisis. The authors recommended ditching the subjective language of hypertensive crisis and instead recommend the term markedly elevated blood pressure. Okay, well, potato. I mean, it's all crisis when the patient just hears your blood pressure is really high. So yeah, in those patients with really, really high blood pressure is really basically what I say to the patient. Your blood pressure is really, really high. I'm like, well, what's the number? I tell them. And they're like, oh, yeah, it does seem high. But when these patients come in with the 180 over 110 or higher and don't have any signs of new or worsening end organ damage, again, the authors recommend not using the current scary term of hypertensive urgency and say asymptomatic, markedly elevated blood pressure instead. That's what I have to say to that. Who cares? Honestly, why is this something that we have to constantly focus on, is this terminology? It's like what we did with delirium. Like it's high blood pressure and it's dangerous. But I guess for practices of communicating about a topic cohesively, we have to make a name and then change it. Physician associate.
Here's why I think it's really important is because this systolic blood pressure or this diastolic blood pressure being high and there being no signs of end organ damage at the moment, that means that it's not dangerous right now.
Okay,
it's
fine,
dangerous.
But Mike, look, we just got done saying that this is one of the most modifiable, preventable, disasters in human health. So to me, it's always a crisis. It's always something that needs to be taken care of either in the next couple of days or at least within a week or two. Because if we're not, look at all the things that we just discussed. So I guess I just get agitated about when people change things like this because what's the point? What is it? It kind of makes people less excited about it. And sure, I agree that not calling it an acute crisis, okay, you don't have to do a workup. You don't have to do this. You don't have to do that. That's fine. But I see you making a face. So, sometimes I get agitated, right?
What if my high blood pressure is because my femur is sticking out of my thigh?
Yeah, but...
Or what if my high blood pressure is because my wife and I were both in an accident and she's in the trauma bay next door and I hear them working on her and I don't have anything wrong with me, but I'm very excited right now and that's why my blood pressure is high.
Yeah, but those blood pressures aren't 210 over, 110. They're like 150, 160 over 90. So you repeat it in a little bit.
Right, but that's what I think this guidance is really good about. It talks about how you have to reassure yourself or assure yourself that this person's blood pressure is really that high. We'll get into this in a little bit, but I actually think that getting rid of these words is very good because the words crisis and urgency imply that something should be done today, that if you ignore a crisis or you ignore an urgency and you, quote, don't do anything that day, that you're somehow harming the patient. I think that this is one of those times where, like Jerry Hoffman would say, Dr. Jerome Hoffman, he would say, don't just do something, stand there. Let's look at this blood pressure. Let's put it in some context and let's make a plan for how we solve this problem that may actually be totally artificial and not be borne out on repeated blood pressure measurements in even a week from now.
Yeah, but I would also quote the late, great Jim Roberts, who said, don't ever miss an opportunity to treat hypertension, whether it's a crisis or not. And I guess, I think maybe we're saying similar things, but I don't think changing the language is really going to make a difference because I still think that with the amount of deaths and issues that we have surrounding high blood pressure and hypertension and the sequelae that come from it, is that it should be considered pretty darn important. And I don't always feel like doing those baseline labs or imaging is a terrible idea for some of these patients because there's so many other things that could be going on. And you're right. Yes, they don't meet criteria to have head CTs. They don't meet criteria to necessarily have a full panel of blood work. And ASAP is very clear about those things. But what if they haven't seen a doctor in 5 years? And in order to see that primary care doctor or get into the clinic, they need a baseline hemoglobin A1C, or they need a baseline creatinine. So to me, I feel like it's always a crisis. And I often will do this for patients based on the variables that they present with. So I don't know. I also just felt the need to argue for a little bit. I feel better.
I'm glad you feel better. Even though we're often faced with patients who have asymptomatic elevated blood pressure or even markedly elevated blood pressure or even a hypertensive crisis, as you might call it, Martha, there's not good data on what we should do for these patients. And recent observational studies suggest potential harms involved with treating them. Lots of studies are cited in this scientific statement that suggest increased risk of mortality, myocardial infarction, acute kidney injury, stroke, hypertension, and ICU transfer in patients who are aggressively treated for elevated blood pressure without signs that the blood pressure is causing end organ damage. This is mostly noted in people who are getting intravenous antihypertensive treatment after they've been admitted to the hospital. And so it's slightly different from our patient population, but you can kind of extrapolate that, if someone still has elevated blood pressure after they've been admitted to the hospital and those treatments are done in that setting, that still caused harm, then maybe in the even more abbreviated setting of an emergency department visit, being aggressive with those numbers could also cause harm.
Okay. So what do we do? Let's answer this question for a patient in front of us in urgent care or the ED who has this elevated blood pressure. And again, there's spectrum here, and there are certainly going to be different things we do for different numbers and presentation. But let's focus on what this paper says. And the authors suggest that first we need to consider the quality of the blood pressure measurement. Totally agree with that, 100%. Is the patient positioned properly with their back supported, their extremities uncrossed, with an appropriate sized blood pressure cuff on the arm, resting at the level of their heart? Has the patient been allowed to rest quietly for, 3 or 4 minutes without talking or listening to anything? And honestly, I let them sit there 5, 6, 7 minutes, and then I do everything else and come back and do their blood pressure last, if I'm the one taking it. I've been shocked at how much some basic quality control on blood pressure measurement results in a double-digit change in pressures. So a recent randomized control trial suggested that there could be a 4 to 7 millimeter of mercury change just due to arm positioning alone. And that's kind of been around for a while. Even in the nursing schools, when I teach brand new nurses how to take a blood pressure, I teach them these you need to do it correctly types of interventions while doing a blood pressure so it's accurate. You also need to consider that smoking tobacco within 30 minutes and a distended bladder are known to cause double-digit changes in blood pressure. And you can put all these things together in a soup, right, in a setting of an urgent care clinic or emergency department, and that can significantly skew someone's true blood pressure when you get them all together. But again, that's usually just their first blood pressure. It's not the blood pressure you do in an hour or possibly 5 hours at discharge.
If you do all those things and you confirm that the person's initial blood pressure is elevated, next is identifying factors contributing to the elevated blood pressure and intervening if appropriate. Acute stress, pain, anxiety, sleep deprivation, illness-related factors. I feel like I'm talking about my November here, but anyways, maybe even not adherence to chronic antihypertensive medications because of a long wait in the hospital. All these things can contribute to at least a temporarily elevated blood pressure, maybe even markedly elevated blood pressure. Of course, also important is identifying signs of true hypertensive emergency, which is defined as elevated blood pressure suspected to be causing new or worsening end organ damage. Hear the term a lot, end organ damage, but maybe you're asking yourself, am I confident that I know what an end organ is and I'm missing any end organs when I'm looking for this?
The authors use the acronym here, BARC-H. Did they, Mike, did you figure out if they pronounce this any differently, or should I say BARC-H?
Yeah, it's like, is it bark? From a Afghanistan or Kazakhstan, like a bark, or is it like bark? I think bark H suits our American linguistic styles.
All right. So the authors use the acronym BARKH, and it stands for brain, arteries, retina, kidney, heart. And this can be used to quickly identify potential target organs at risk. So there's a nice little table in the document that runs through the specific conditions to be concerned about. This is not necessarily a comprehensive list, but it's a good starting point. So here we go. B is for brain. Consider stroke, hypertensive encephalopathy. Yes, the Press syndrome we talked about earlier, or cerebral hemorrhage. A for arteries, aortic dissection, preeclampsia and eclampsia. R for retina, hypertensive retinopathy. K for kidney, acute kidney injury and thrombotic microangiopathy. And H for heart, acute heart failure, pulmonary edema, and acute coronary syndrome. So evaluating for these conditions will, of course, require a solid history and physical exam. And on the physical exam, there should be a focus on comparing bilateral pulses, listening to the heart and lungs, and doing a fundoscopic exam on the eyes.
And with that fundoscopic exam, I think you just do the best you can. No one's expecting you to do a dilated eye exam on every one of these patients, but like you give yourself the best chance, right? You turn the lights out in the room, you really take a second, position the patient, position yourself. You just do the best chance you can, and you can just document that, hey, I did a non-dilated fundoscopic exam and I saw whatever you saw. Okay. In terms of diagnostic tests, so like labs and imaging, depending on things like clinical presentation, and maybe you wrap in some social determinants of health in your decision making. We kind of hinted at that earlier. We'll come back to that in a moment. That includes things like a basic metabolic panel, a complete blood count, a chest x-ray, a 12-lead ECG, including checking the heart rate and confirming that, and an assessment of volume status and maybe some sort of orthostasis. The authors do point towards the 2017 hypertension clinical practice guidelines for treatment if signs of hypertensive emergency are discovered. However, rates of hypertensive emergency are quite low, somewhere between 2 and 10 patients per 1,000 that visit the ED, and thankfully mortality rates from hypertensive emergency have been decreasing over the years.
So let's say you've ruled out a hypertensive emergency in your patient, and now it's time to discharge them. What do you do? As we know, newly diagnosing someone with true hypertension often requires multiple elevated blood pressures recorded during multiple encounters over a short period of time. But it's important that we call people's attention to their blood pressure and your recognition of a blood pressure, whether it's the patient or someone else that comes across their chart in the future. I like to talk to the patient about this at the end of their visit, about the fact that their blood pressure was elevated at the time of their visit and the documentation of it in their chart that I'm hoping that they will take back to a further discussion with their primary care doctor or follow-up clinic. If they've already been diagnosed previously with hypertension, I think it's fine to give them the diagnosis of hypertension and a discharge diagnosis. I also like to put something on the front page of their discharge paperwork saying what we talked about and what to do next. And Mike, do you have any preferred verbiage that you like to use in this situation?
Yeah, this is what I write for those people with, again, if they already have been diagnosed with established hypertension and they were at least prescribed medications at one point, whether they're taking them or not is kind of immaterial. Your blood pressure was elevated today. It is important you follow up with a primary care practitioner in, I say 2 weeks, but I understand this is kind of like maybe not reasonable for certain people. So let that be kind of a point you can kind of fiddle with. But anyways, I usually say in 2 weeks for reevaluation of your blood pressure. Continue taking your blood pressure medications exactly as prescribed, but ask your primary care practitioner if you need different treatment for your blood pressure. Failure to follow up about your blood pressure could lead to disability or even death. So that's my little verbiage that I have a little, quick documentation efficiency phrase in my microphone. And I say something like, put follow-up hypertension, and it spits out that paragraph. It says, essentially, your blood pressure was elevated. We both see that it's elevated. Get your elevated blood pressure checked out. And if you don't, there could be serious consequences. Martha, how about someone who happens to have Just elevated blood pressure during a visit, but no previous diagnosis of hypertension. You look back in their records, they've never been seen in your system before. You ask them, has there ever told you have hypertension? They say no. What's hypertension? How do you handle that communication with this person?
A lot of variables here. If you really is what you just said, there's no documentation, or let's say there is documentation. It was 120 over 80 the last time they were seen in the office, and that wasn't that long ago. Sure, I mean, I don't need to jump all over their blood pressure and start them on Norvasc or diuretics or anything like that. But if they have consistent visits either to my department or somewhere else, and I'm like, oh wow, it's been 160 over 90, it's been 175 over 100. Like, if I can see documentation of this, I'm going to start them on a little something. Like, only because a lot of the patients that I see in our clinic, in a county hospital, we see them over and over and over again. Again, your shop may not be like this. And I understand that my opinions and the way that I go about treating these patients is a little bit different than some people may do. But the overall point that I would like to make is, of course, you're not going to just throw antihypertensives at a patient with just a few measurements of high blood pressure. It's just, that's not appropriate, not appropriate based by the literature, not appropriate based by, traditional practice. It's not appropriate, and you're not going to see them again, probably. But if you have a special population like mine, I think it's important that maybe you do get the labs, or maybe you do get that one particular test that they need to see follow-up in that clinic. And I guess overall, I just get irritated that this is such a preventable disaster. And I just want to focus on the positive things we can do from identifying it, as opposed to avoiding, doing anything at all. And sometimes I don't really care if it's not liked by, the nurses, like, oh, we don't want to get blood tests, or, we don't want to do this or that because this patient doesn't need it. I mean, they're not really thinking about the long-term outcomes for that patient. And I like to do that. So yes, do your treatment based on recommendations in literature. But if there's a certain patient that you'd like to do more for, you should do it. And if there's variables that direct you to start an intervention, do it. It's my opinion.
I'm so familiar with the name for this diagnosis because I see it all the time, and I use this all the time, that I even know the ICD-10 code. It's R03.0, and it's elevated blood pressure reading without diagnosis of hypertension. So that's the appropriate one for you to use. If there's not a lot of lists or visits with elevated blood pressure, they'd happen to have it for the first time or rarely at your visit, that is the diagnosis that I give them. And my verbiage in the first page is very similar. I say, your blood pressure was elevated today. It's important to follow up with a primary care practitioner within 2 weeks. Again, do with that what you will in terms of your practice setting, how realistic that is. You've got to write a date down that is realistic for you and the patient. But anyways, within X weeks, to see if you need further tests or treatment. Failure to follow up with a primary care practitioner about elevated blood pressure can result in disability or even death. So again, kind of covering the same bases and ensuring that it's clear that I mention to them how serious it is. There have been cases from the medical legal literature about people who, like, it's one of those things where it's just like, oh my gosh, like, did the clinician not do every single thing for this patient, and yet they're still being sued? Like the person, I had identified that they had elevated blood pressure, and they said, go get that checked out. The person never did, and they ended up with like kidney failure. Mm-hmm. And so the perceived slight against the clinician was, well, yeah, you told them to get it checked out, but you didn't tell them how bad it could be if they didn't get it checked out. And it's just like, oh my gosh, like that is really nitpicking of the role of the clinician here. So I just like to head that off the pass, and I put that short statement there as far as like, this is a serious thing. You should get it checked out.
Totally agree with you. And it's just like these cases that I sit in on, when a lawyer says to you, this is one of the most, if not the most preventable cause of X, Y, and Z sequelae and things that this patient had. Like, you knew it, you didn't do anything about it, you didn't alert them. one of the most basic, well-known things in healthcare is high blood pressure. Like, what's the deal? So, yeah, of course, that's a great little tip that you put in there for people. And, just to add on what I said earlier, again, thinking about those social determinants of health that could affect their follow-up, financial stability, housing, homeless patients, things like that, uninsured, underinsured, low income, health literacy. Yes, all of these things, and consider the resource that you have for these patients. And maybe you have a packet that you can give them on how to get financial assistance, or have registration come and check with them, those types of things. These are nice little what do I call them? Just little tidbits of things we can do for our patients to have them have better health careers. And you've heard me make that statement before. Your health is a career. You need to constantly be investing in it and make changes based on, how old you are. And I think another really good, important thing we can focus on is knowing your patient population and how comfortable you feel starting patients on medications, or, hey, calling that primary care clinic office and getting them some follow-up. So again, I know I get really heated about this topic, Mike, and I'm not trying to disagree with the paper recommendations at all. I'm not disagreeing with them. My level of agitation around hypertension just seems probably disproportionate, because I've had so many patients that are just it was easy to prevent their problem. I've been seeing them for years. It was easy to prevent their problem. And it makes me sad that we don't take it a step more. Ignoring it or saying it's not our job, or like we're just this emergency department, and, I kind of say, like, have a little guts here to do the extra. Because you're just going to see them when they have their stroke or their heart attack anyway, and maybe it could have been prevented.
Well, maybe to make you less sad about it, will 30 days of blood pressure medications out of the ED really impact this person's care over their entire career, as you say?
No, and we looked at studies, those 30-day studies. They're not great. I know they're not great. But it's just like putting scary words in their discharge paperwork that say, like, you really need to quit smoking, because if you don't quit smoking, you will die from this. So maybe something like, if you don't get this blood pressure treated in the next month, you will probably die from this. Like, putting extreme things in charting is an art. And I highly suggest kind of seeing what your colleagues do and combining it into something you really like for patients. Just like you said, that diagnosis of it's hypertension, the diagnosis of high blood pressure without the diagnosis of hypertension.
Well, I think this document is really great, frankly. I think it can really inform our practice on a very common issue, as you say. It's one thing to have ASAP give a clinical practice guideline, but as far as the overall house of medicine, no one really cares about what emergency medicine doctors say beyond emergency medicine doctors, right? So this is the American Heart Association. They are bringing the receipts in terms of all the studies that show that, like, be careful about overdoing it in the hospital. So, like, don't feel the need to overtreat while they are in the hospital. It also does speak to everything you're concerned about, Martha, and everything I'm concerned about too. Like, it is just really, it's a pleasure to work in county emergency medicine like you do, because our hospital recognizes the plight of our patients and how, like, we can't just discharge them from the ER and be like, that's it, we're washing our hands of you. Like, there are so many resources to connect my patients and my current ER with primary care. It's very reassuring to me, and I make sure I take great pains to do that on their way out the door, so that they can kind of continue to further their health career, like you say. This is a very short document. It's 10 pages, and every single page has something important on it, in my opinion. And what's nice too is that you can, like, this is a very easy one to kind of point your colleagues to your fellow clinicians, to your nurses, in case people are like, why are you doing it this way? Or why are you not doing a certain thing? You can direct them to this document, and it's a very short and sweet. Links to the document will, of course, be on our website. That is 2view.fireside.fm. That's the number 2view.fireside.fm.
All right, it's time for our two-part trivia question, and we're going to go all the way back to our first segment on this one. Whew, seems like a year ago, right, Mike? My ranting and raving. Reversible cerebral vasoconstriction syndrome is also known as a syndrome named after two physicians who were the first authors of a set of case studies in 1988. Okay, well, what is the name of the syndrome? And tell us the name of the two physicians.
Email us your two-part answer, in addition to anyone else you'd like to give a shout out to, as well as any feedback or comments on the episode or our new format. It's not new at this point, to 2viewcast@gmail.com. That's the number 2viewcast@gmail.com. And go check us out on the Instagram. I'll be doing it for the gram here in a bit for CCME_courses. You can see my cool bleeding control kit that I have in every single one of my family's vehicles, just in case they need it.
And our winner last week was Audie Chandon, a brand new MP grad. So congrats, Audie. We'll see you in Las Vegas.
It's great. Well, more information on the original and advanced emergency medicine boot camps, the emergency medicine and acute care course, the mastering pediatric emergencies course, or any of our courses are available at the Center for Medical Education website. That's www.ccme.org, www.ccme.org.
And like Mike said earlier, new and upcoming courses we're announcing all for 2025. So keep checking back for the rest of our links and courses that are coming.
Thank you for listening and attending this episode of The Two View. You can subscribe and rate us. Please rate us on Apple iTunes Podcasts, Spotify, YouTube Music. Search for Two View Emergency. That's the number 2 View Emergency. It'll come right up. Ratings helps us climb the charts so other clinicians get some Two View goodness just like you have today. If you like YouTube and you want to see the video blog instead, search for Center for Medical Education on YouTube and you can watch the video version. Don't forget our website where you can go next level any of our topics from any of our episodes. You can get all the papers we referred to today. That's 2view.fireside.fm. Our audio and video engineers are Ricky Bucata and Dave Pett. Show notes are by Meg Dipple.
Thank you again for tuning in, friends in EM. Share this podcast with a friend and share your thoughts via email. And thanks for sharing your time today with us on The Two View. Have a good day and a great shift.
Go Ravens.
Bye for now.